Welcome, everyone. It's my pleasure this evening to introduce our speaker. Dr. Joyce Knezdrich is a professor at George Washington University, and she is past president of the American Association of Nurse Practitioners. Dr. Knezdrich practices as a primary care provider in rural Appalachia, caring for low-income and underserved populations. She has been a family nurse practitioner for over 30 years, a nurse educator for over 35 years, and is active in maintaining high-quality education for nurse practitioners. Her research is focused on health and access to care for low-income and rural populations, particularly women, nurse practitioner workforce issues, and distance education for nurse practitioners. Again, it is my pleasure to welcome Dr. Joyce Knezdrich as our speaker this evening.
Thank you so much for having me. It's always nerve-wracking when you see your fellow, your graduates. I see at least one of my students in the class, and then I see one of my mentees here tonight. So it's always, I always feel like I really have to put on a good show because they're watching me. So, but I'm glad you're all here this evening. Please, if you have any questions, please put them in the chat box. I don't know that I could see it while this, feel free to interrupt at any time. So I want to talk a little bit tonight about nursing leadership and building the future. So my disclosure, you could read that. Frontier University is accredited provider of nursing continuing education by the American Nurses Credentialing Center Commission on Accreditation. And this tells you about the information related to your contact hour for tonight. I am an employee of the George Washington University, and the relationship has been mitigated. There are no financial relationships or conflicts of interest to disclose. Thank you. So congratulations to anyone who's a new member of Sigma. And Sigma is one of your sponsors. So I want to remind you how very important it is today for Sigma, because we really need to develop nurse leaders anywhere to improve healthcare everywhere. So not only here in the United States, but across the globe. And it's just so far-reaching what we need to do to improve healthcare, because we've seen from the COVID epidemic, what happens somewhere else will happen to us eventually. And the vision of Sigma is to be connected and empower nurse leaders in transforming global healthcare. So I think it's important to talk about these issues in terms of building the future for nursing leadership. Tonight, I want to talk about healthcare as it continues to change, and nurse practitioners and certified nurse-midwives are well suited to be movers and shakers to impact policy and health reform. And I want to talk about nurses as leaders, particularly nurse practitioners and midwives bring experiences to improve social determinants of health. And we are often the voice of diverse patients that we serve. And I feel obligated as someone who serves patients, and I live in Mid-Appalachia, to be the voice for people who cannot speak for themselves on their health issues. And we really need to work on the removal of barriers to practice in federal, state, and local health systems, not only for advanced practice nurses, but for nurses. And the readiness to meet these challenges really comes, I want you to think about your reflection in your personal self-reflection and reflection on your profession. So I want to describe the current state of NP practice in the US and why nursing leadership is essential. I want to analyze the role of the nurse practitioner and midwife in the Future of Nursing report, and propose ways to remove barriers to state, federal, and local health systems. So nurse practitioners and certified nurse midwives are advanced practice nurses. They're two of the roles, and that over 25% of primary care in the US are provided by advanced practice providers. And I think that number is growing as we see less and less physicians going into primary care, and we see more nurse practitioners and midwives in the OB, women's health arenas, filling these roles of primary care, and oftentimes in the most underserved areas. And we are leaders in healthcare. We are the change agents that have been created in healthcare, and we were at one time a disruptor. The question is, how do we maintain that, and how do we move forward? So we know that we provide high quality, cost effective, evidence-based care. This is important because adversaries to us always want to point out that we're not as educated, or we don't know as much. Of course, they have nothing really to prove that, but we have the evidence to show from studies, even published in their own journals, that we provide high quality, cost effective care, and that we know how to create systems, because we have these wonderful DNP graduates who are looking at things at the system level to make changes at the national, state, and local level to address social determinants of health. And in that local level, I include your hospital health systems, because what we're finding out is that many times where we make advances in some states, we still have issues at the local level, at the hospital level, that are impacting the ability and creating barriers for nurse practitioners. So we're making changes in our health system, and that's important for nurse leaders, because we want to have full practice authority implementation for nurse practitioners, and midwives already have that, but they want to be able to use it to the full extent, because we need to improve access to primary care providers in health shortage areas, and increase ownership of practices among NPs, which I know one of my DNP students when I was at Frontier was a midwife who started a practice that became an FNP because there was not enough providers in her rural area in Florida. And although she worked at that time in one of the most restricted states, she was able to get access to care both for midwifery and for family services in that shortage area. So we work and we want to lead access to care in rural areas, access to care in underserved areas, and access to care for minority and other underserved populations. And of course, as my research has been on these populations, so you know it's near and dear to me as well. So how many, and I can't see this, but if you could just raise your hand if you work in an underserved area, just so I can get an idea. There's more. Okay, Nancy, Stephanie, Joanne, Audra. So a lot in this group are working with various underserved populations. And the recent nurse practitioner workforce study, which I was part of the research group, was published by Chris Tracy, the vice president of AANP and all. We compared nurse practitioners in non-full practice authority states and nurse practitioners in full practice authority states. And currently we have 27 states who have full practice authority, and Washington, D.C., and 2 territories in the United States. So I'm hoping now that we have about half, that will maybe grow a little bit quicker. I'm hoping my own state of Pennsylvania will meet the criteria. I do not have any agreement in West Virginia, but if I decide to do Schedule II medications, I would have to have one, and so that's keeping us at a reduced status according to AANP in West Virginia. But you know what we found in our study is that if you are in a full practice state, you are more likely to be practice owners or a shareholder in that practice, which is very important for your employment, that you can be part of the shareholder even if you're working within say a physician or a clinic practice. And we found out that a greater number of patient visits were billed under their own MPI number if they lived in a full practice state. So there was no incident to billing. One of the major problems with incident to billing is it makes it very difficult when we see the number and the data to identify who's giving the care. And so we can't always get the most accurate data on what we're doing as nurse practitioners or nurse midwives if we're not billing under our own NPI numbers. And so in full practice authority states, you're more likely to see that. Having full practice authority for greater than or equal to 10 years was actually associated with greater improvements in conditions of employment compared to having full practice authority for less than 10 years. So some of those states that have had a long time full practice authority in their states really have better employment outcomes. And I think it's because so many states have so many hours that you have to practice under a physician or another NP before you can be considered full practice. Sometimes it can take up to 5 years in some states before we actually see that improvement. And states adoption of full practice is really associated with improved conditions of employment. And I think that's really important to note because, you know, we really try, and I think Frontier has always done a great job of trying to educate people in their communities so that they stay in that community and they provide that vital care to people in those communities so they don't move to a city and find out they like Starbucks and move back home and there isn't any. They're very committed to the community in which they came from. And we need more people to be in communities that look like them, talk like them, act like them. That's really, really important. And untethering nurse practitioners particular, and I would say midwives in some cases, from physicians establishes a cascade of modest gains in income and practice over ownership that really we see changes over time. We're not looking at big income gains like I think some other professions are worried that we're going to make, because usually we're in those areas. I see all underserved, uninsured, and Medicaid patients. I'm never going to get rich off of seeing those patients, right? Because my goal is to do service to that area and to make sure that they have adequate care. And so I think we see a lot of nurse practitioners, midwives working with those populations. So while we see modest gains, we don't necessarily see huge gains, mostly because of the populations that we serve. Anyone surprised by this data? No. Okay, so nobody is really surprised at the data. Yeah, so we still have a lot of work to do as nurse leaders, though, you know, to make sure the momentum continues, to make changes in our states in order to keep the momentum going and continue to be disruptors. So how can you as a nursing leader transform healthcare in the United States and maybe even globally to meet the challenges of the future? Well, Dr. Loretta Ford would say, you have to turn hindsight into foresight to make a change. So we can look behind and say all of the things that we have done right or wrong, right, in the past, and how do we learn to build upon that and make foresight to make change? Because leaders are always learning from the lessons that they've learned in the past and always trying to move forward to make it better. Dr. Ruth Lubick, who started a clinic down in one of the most underserved wards in the Washington, D.C. area for women's health care and midwifery, says nursing prepares you for excellence. Be proud that you're a nurse. I wish that everyone could hear Ruth Lubick talk now about being proud to be a nurse. And I think Lee Ford would also say, you know, keep nurse and nurse practitioner, and that you should be proud to be a nurse, because we should be proud to be nurses, whatever level that we're practicing. And we should be encouraging young people to come into the field of nursing. I think that the COVID-19 pandemic, although it included us in the heroes, there was also a lot of negative publicity about nursing and the burnout and the long hours and the sickness and the nurses that died. And so young people are looking at that and saying, why do I want to be a nurse? This is not a place that I want to go. And we need to change that picture, because we can't get nurse practitioners or doctor of nursing practice prepared, or PhD prepared nurses, if we don't have those people interested in coming into our profession. And who loses out? The patients and the families and the communities that we serve. So of course, we're not all Dr. Ford or Dr. Lubick, but everyone here and every nurse practitioner or midwife have the capacity to embrace and shape the future. And I hope that you will think about your capacity to do that after this talk today. Remember that leaders will not just embrace the future, but we will create the future. We have to start making changes to create whatever this future is going to be. One way we can look at it is to look at the Future of Nursing report. Some of you may be familiar with it. Some of you may have heard of it. Some of you may have never even looked at it. So I think it's important to talk about the Future of Nursing report, this new one that's out for 2020. Many of us are still quoting the old IOM report before it was the Academies of Medicine. Now it was the whatever the IOM stands for, of Institute of Medicine report. That was the first one that came out that talked about removing barriers. And while we still have that elements in this report, we were really talking more broadly about how to achieve health equity and nursing's role, and certainly nurse practitioner and nurse midwife roles. And outcome one, nurses are prepared to act individually, through teams, and across sectors to meet challenges associated with an aging population, access to primary care, mental and behavioral health problems, structural racism, high maternal mortality, morbidity rates, and the elimination of disproportionate disease burden carried by specific segments of the US population. And I think nothing brought that out more than the numbers from the COVID-19 pandemic. When we look at the number of elderly, our aging population that died, that were affected, when we look at the number of our racial subgroups that were strongly impacted and died from COVID-19, when we look at the impact on maternal mortality and morbidity based on that disease burden, and particularly in specific communities, we really need to start looking at all these issues. And nurses, because of the way we're educated, because we look at the whole system, the whole person, the whole community, we are able to be the ones who can act to address these issues. Outcome two, nurses are fully engaged in the underlying cause of poor health, individually and in partnership with other disciplines and sectors, and they act on a wide range of factors that influence how well and long people live, and helping to create individual and community targeted solutions, including health policies orientation. So think about this in terms of our population health courses that we have integrated into our programs, and why it's so important to think about population health. How are we going to address social determinants of health? And how are we going to educate other providers and other disciplines about why it's important to look at targeted issues in communities? Because nurses are often looking at that psychosocial determinants. And I'm certainly happy, and I hope we have some psychiatric nurse practitioners here, mental health, because I think, we can't do our job without addressing mental health issues in our country today. Nurses reflect on people and communities served throughout the nation, helping to ensure they receive culturally competent, equitable healthcare services, and that healthcare systems enable and support nurses to tailor care to meet the specific medical and social needs of diverse populations. Now, I didn't know where everyone was from, and I'm assuming because people went to Frontier that you're from all over the country. So I looked up a few things. related to specific areas when it comes to communities. In Kentucky, Clay County, Kentucky, is the median household income is $27,479. Household income, not individual. You know, Clay County is not very far from Leslie County. Leslie County was where Mary Breckinridge was from, and the original Frontier School was located. So I think, yes, people are frustrated at the legislative. No one listens. We'll talk a little bit about that later. Good point, though. But if you think about the average, that's 47% below the state average, and 57, almost 60% lower in Clay County than the national average of a median income. And the households earning less than $15,000 a year, could you even imagine trying to live on $15,000 a year, is 28% in Clay County. It is the 18th highest, so I guess it's really the lowest among counties nationwide. So among the 18, among the poorest counties nationwide here in Kentucky. Now, as you know, Kentucky is probably pretty homogeneous, just like West Virginia, where I practice. So the majority of people in that area are going to be white. In Oldham County, Kentucky, about only 2.9% of the families and 4.4% of the population are below the poverty line, and 95% are white. In my local area, Fayette County, which borders my county in Pennsylvania, the average household income is $19,000. 89% of the population there is white, and in Chester County, the household income is average is $85,000. They have 76% white, 8% Latino, and I think 17% African American or Black. So, and then if you look at Tennessee, which is a border state of Kentucky, they have some interesting outcomes as well. Hancock County, their median income is $29,000. That's 43% below the state median. They have 22.5% of the families live in poverty. They are 97% white, 2% Hispanic, and 0.7% Asian. In Shelby County, 13.7% live in poverty, and it's 52% African American or Black, 60% Caucasian, and 6% Hispanic or Latino. So in Davison County, where Nashville is located, where they consider themselves to be home of Health for the South, their largest county, Davison County, is 55.7% white, African American or Black, 26.4%, and Hispanic, 10%. The median income there was better at $66,000, but 10% of families there live in poverty. In Florida, their poorest county, 60% white, 11% Hispanic, and 30% are Black. And I can't read my numbers, but anyway, the most wealthiest county in Florida, the mean salary is $73,153, or the mean household income, and that's in the Key West area. And it's interesting that in New Jersey, Atlantic County has the lowest ranking. They have 42% African American or Black, 25% Hispanic, and 19% white. They have a high maternal mortality. They have 38 out of 100,000 deaths, and it's the fourth highest state in in more infant mortality, maternal mortality in the country. So we can see that there's diversity uh, in the numbers, and it's diversity in the people that are represented in those groups in these different um, income ranges. And we know that the income range is directly related to the health outcomes as well as education. So healthcare systems, we really want to look at leadership for healthcare systems to support nurses to tailor the needs to meet those social needs of diverse populations to optimize their health. So if you're working in those areas that I mentioned, or any low income or underserved population, you really need to work with the health system, who is oftentimes the the place at the local level that is creating more barriers for nurse practitioner and nurse midwifery care. And it's oftentimes hard to get nurses on these boards, and it's difficult to get a nursing voice. But if you have the opportunity to have your voice heard, this is a really good way to go to meetings and to voice your concerns for the population. Outcome 5, nurses' overarching contributions, especially those found during COVID-19, are quantified, expanded, and strengthened, including the removal of institutional and regulatory barriers that have prevented nurses from working to the full extent of their education and training. This is where that piece from the IOM report is back in. And practice settings that were historically undercompensated, such as public health and school nursing, are reimbursed for nursing services in a manner that's compatible to that of other settings. And unfortunately, I don't think we've actually seen that happening outside of after COVID. In fact, we really saw a lot of states have limitations in their public health programs. And so we really didn't have what we needed public health wise to address the needs of populations in various states that were hard hit by COVID, including students in school nursing. So we have a deficit of school nurses, and they have a lot more responsibility. And we have nurse practitioners as well in those settings that have more responsibility but less pay. Outcome 6, nurses and other leaders in healthcare and public health create organizational structures to process and facilitate the profession's expedited acquisition of relevant content expertise to serve flexibility in areas of greatest need in times of public health emergencies. I read that and I think, how many academics, I'm sorry if any of you are academics in here beside me, but I read that and I think, what does that exactly mean? And why did they write it like that? Because it seems very like they got in a room and argued over the words. But I think it's very important for us to think about the doctor of nursing practice and your ability to do systems and look at organizational structure. You can really lead change in this area to talk about expertise and how we can best serve the greatest need in times of public health emergencies and disasters. Because oftentimes, even though we have more over the state licensures for RNs, nurse practitioners can't go across borders and practice without a license in that area. So they're not able to really practice to the full extent, and even sometimes in their own state. If we looked at health outcomes, at the outcomes 7 and 8, we consistently incorporate health equity lens through revamped academic and continuing education. And I think if you look at the new AAC and Essentials, you will see that they really incorporated that health equity lens into what we are going to be doing in our education programs, which are vital for us to be able to lead healthcare in the future. And that nurses collaborate across affiliated organizations to develop and deploy a shared agenda to contribute to substantial, measurable improvement in health equity, and that national organizations reflect on diversity, equity, inclusion within and across their organizations. So I have to applaud Frontier Nursing University for the work that they have been continually doing to really impact diversity, equity, and inclusion within that system and within the organizations affiliated with the school, so that as you go out and you are the nurse leaders in these communities, that you are looking at this from that lens, and you are looking at it from the lens of how do we make this world a better place for everyone. Um, and that we can address social determinants of health. And as you saw in the numbers that I gave you earlier, that it's not necessarily only minority populations that are affected. In Appalachia, it's primarily white populations, but they're underserved and they're poor. Outcomes 9 and 10, nurses focus on preventative person-centered care. Now, we are really bad in this area, right? We have to learn how to take care of ourselves. And I think the pandemic really shed a light on the fact that we need to learn how to take care of ourselves so that we could teach other people how to do preventative person-centered care. Other people want to run into nursing's what's always been nursing. We have very, very much from the very beginning with Nola Pender and some of the early nurse theorists talk about person-centered care, health promotion, prevention. This has been a nursing role, and we want to keep it nursing because we do it best. And nurse practitioners and midwives, we work on taking care of the person. We put the person in the center of the care. So we think, that a person's care should be led by whoever the person needs to lead their care. So it might be a nurse practitioner, it might be a physician, it might be a midwife, it might be a specialist, it might be a physical therapist, because it just depends on what they need for their care. Now, I'll tell you a little story about my nurse practitioner. I went for my exam. First of all, I go into the office, and so I'm just standing up on one foot, because I'm old and they have to do that get up and go test, and I refuse to do it. So I just wanted them to see they didn't have to do it on me, right? Because I have perfect balance and I can get up and go. But I don't even think the person in there noticed anything. And I got up from the chair and I sat, and she never noticed anything. And then the nurse practitioner says, I want you to start on this statin. And I said, because you're at a 6% risk of developing heart disease by the time in 10 years. And I said to her, well, I don't want to start on a statin. I have my family members have side effects from it. I don't think my cholesterol is bad enough to start on a statin, and to the benefit of it, I don't think outweighs the risk. And I think that, in 10 years, who knows if I'll be alive? So what will it matter? And so she got a little bit frustrated. And then she made me sign a document saying that I refused to take the statin. So I said to her, I am going to sign this, but this is a kick in the butt for patient-centered care, because you haven't listened to anything that I had to say about my own health, about my own wellness, and about my own concerns. So then she sat back in the chair a little bit and said, yes, I guess you're right, but it is our policy here. So this is systems changes at the local level, at the very provider care level. And I said, well, how can you change that? And again, she just looked at me, because I said, it's not, while it is preventative, it's not person-centered. You didn't hear what I was saying. So we have to really think about how we can incorporate that into our practice, because people are looking for that. And we need to attend to our own self-care, because like I said, we're bad at that. And we need to ensure that nurses' well-being is addressed in education and employment settings, and the implementation of evidence-based strategies. So things from, I've had people, I think one of the students I had here at Frontier did a DMP project about changing the vending machines, what was in the vending machines at her place of employment, to try to improve the obesity that she was seeing in that place of employment. So you could start small, but that can make big changes in the end. And you could also start by caring for yourself to show others. And I think that we saw, as effective the pandemic, that nurses did not necessarily self-care, and that we've had many nurses that died or were greatly impacted by long COVID and the long-term effects of COVID-19. And we don't know what's coming up with other pandemics. We know that too many nurses are working 12-hour shifts, 16-hour shifts, and they say they like that, but we have to really consider, is that healthy? Is that something that we should be engaging in, or should we try to make changes in that area? Remember that nursing is the most trusted profession. And so what does that really mean as a leader? It really adds a responsibility to be a voice for healthcare. And you can be the voice for one person, one other nurse, the healthcare system in the state or in the US. Perhaps you only write a letter, and I know someone said they don't listen. Trust me, I've written a lot of letters to people who give me these answers back. And I've been on the phone with a lot of legislators, or I've met with them in person, and I've been to the White House talking about these issues. I testified before Congress. And I do want to say that they really did somewhat listen, but I don't know. And some of the issues were addressed that I brought forward, but I don't know that we'll ever get there. So we have to really keep on it, and we have to keep doing it for our patients and for the health of this country. And whatever level you're working at, as if it's only your one person you're advocating for, one other nurse, or the big system, you need to be the voice of change, and you are educated to do that. The time is really right for us to make change and have our voices heard. This is really important in the United States because our population is aging. It continues to age, and the healthcare costs are soaring. And our outcomes are not the greatest in the world. Our life expectancy is decreased not just because of COVID, but because of opioid use, because of our lifestyle, because of our food. All of those things are causing our life expectancy to drop, not to even mention how bad our maternal and infant mortality and morbidity rates are in this country. They're worse than any of the countries that are close to us. But you know what? We're nurses, and we know how to fix things. We know how to save cost, and more importantly, we know what it's like to save lives. And that's why, as nurse leaders, we need to get out there, bring more nurses into our profession, bring more people into our community to make change, because that is the only way we're going to change this healthcare system. I want to bring up a few futurist predictions. John Carroll says that within the next 10 years or so, wellness programs will be considered an integral part of most organizations. And they'll offer incentives for employees who participate and meet their goals, but they'll penalize people who don't. Now, we're already seeing this with some organization. We're already seeing this happen with some insurance companies. But we're also seeing a pendulum swing to the other, where people are saying we should go back to the old way of only doing sick care, sick insurance. And I think we're seeing that a lot with people with high deductible insurances that are only there if they're hospitalized. They're not really seeking wellness or preventative services. This really aligns with outcome 9. I'm not going to read it again, but so we have to think as nurses, how can we help those people that are not reaching their goals, so that they're not penalized, that they're not being held accountable for something that's almost unachievable for them. You think about how hard it is to get a 30-year 3-pack a day smoker to quit smoking. It's not going to happen overnight. And how do we get those people who want to reach their goals? How do we get them the medications that they might need, the services they might need? What if they live in a neighborhood where they can't go out and walk because it's not safe? Or, how do we get that to happen? Because nurse leaders know the communities, and we know what can be done to make those changes. Futurists said that in 10 to 20 years, growing organs will not only save lives, but it will also save the cost of treatments. Well, I think we're already doing that. I used to use a thing from a National Enquirer about a mouse growing an ear, and had the students go back and look to see where the original sources are. And I think I should do that on everything that comes on the news today. Have everybody go back and look and see where the original sources, and is that news channel giving you true or false information? And it doesn't matter where you are politically, it's both on both sides. But growing organs, there was a story about a mouse growing a human ear, which was not totally true. The human ear was implanted by scientists on the mouse and was growing. So you see how you could twist things so easily. But this is important because our aging population is going to require better and more efficient ways of managing their health. And they are going to body shop when parts wear out. And you don't know how many people in my age group have knees replaced, hips replaced. And sure, I know one person who has both knees, one hip, and one shoulder replaced. And they're still out there working pretty hard. So people are going to body shop, and they're going to try stem cell, and they're going to try new, less invasive surgeries. So I think the futuristic prediction is right. But how can we keep our aging population from even having joints that wear out? I think that would even save more costs. I'm trying to get my new slide here. But the other thing we have to think about when we start looking at these issues is ethical decision making. And nurses, we know how to think ethically. We are trying to always think about what's best, what's ethical, and focusing on that patient-centered care. So that prediction might also be part of outcome 9. Data and machines and algorithms, ever hear of AI, right? Are used to manage and make sense, and it could largely replace independent decision making, large or small, and it is happening at such a speed that it's sometimes hard to remember the data isn't in control. The data comes from a machine. The machine does not know if it's accurate data or false data. Garbage in, garbage out. It can't clean the data. It is only following the algorithms that it's programmed to follow. People still control the data, but who has control, and what will they do with it? This is going to become, and already is, an ongoing challenge. And nurses have to learn how to use the data, and not necessarily control the data, but give the evidence about what's wrong with the data or what's right about the data that's coming out from AI. So let's work with AI and control the data. I'm having so much fun with this AI. I can't even tell you. I mean, I've been using it for a while because I'm always interested in new things, but I use it a lot for idea generation, and it's amazing. But the key to remember is that I have the brain to think about the right questions to ask and to determine whether or not that information it's feeding me is true or false. And if you don't have the bandwidth to do that, and you're only following what AI tells you, then you're going to have an issue, at the end. And as the educators in the room, we need to watch students that are using AI. There is a story about an attorney who looked something up on AI, tried to defend a whole case, and all the information was false. So we have to be very careful about how we use the data, but we have to use our brains. And I think nurses can be the ones who really lead this by saying, you know, that's not exactly true. And this is the evidence that we see, and this is why we do it like this. So we have the knowledge and expertise to help develop new technologies. We can create and manage and help to ensure that AI is used properly. And we can think about what is the role of the nurse in making sure that patients have correct data and information. And we saw a plethora of wrong information, not just because we didn't have the data at the beginning of the COVID-19, but even when we did, wrong interpretations and misinformation that was given out. And for people to understand how long it takes the scientific process on a new disease to come out is the biggest thing that people, I think, needed to understand, particularly in our culture when they want a quick fix. So how can we use this to make sure that the data are and information are correct, and that people know how to find out the accurate information? And if they can't find it out, how can we show them that we can? So I think it's real important. I used to think that one day the difference between nurses and physicians may be that AI gets so popular, and I think I'm going to talk about this in another slide, that at one time you could just put your hand up on a screen and the computer could tell you everything that's wrong with you, and they're already working on this, but it can't replace that human touch. It can't change your diaper. It can't give you a bath. It can't talk to you. It can't listen to you the way that nurses and nurse practitioners do. This is kind of a sad prediction that 16 to 24-year-olds, from those unschooled to those with doctoral level educations, live in the world where they may be stuck at home without a job prospect for years. Now, I launched all my children out, and I don't want them back. I love them very much, but they can stay away. But I couldn't imagine what it would be like to keep them at home without a job prospect. And all of this discontent then may breed unorganized anarchy or rebellion in a form of a technological or infrastructure sabotage, either physically or in cyberspace. So if you think about these young people and how they know and how they learn and how they communicate, it's really not physically. And so how are we as nurse practitioners going to reach out to try to help this group of people if we're still trying to do our care the same way? How will we prepare our infrastructures, for this cyber anarchy? I work in a really small, little, underserved clinic. Do you know that somebody took our data for ransom? I don't know what they got out of it, what they would think they would get out of it. But it has turned our whole clinic upside down in terms of what we do for security, for cybersecurity. And at least one thing, I think our system is more prepared for it now than it was, but I don't know. And all of us will have something to do with mental health interventions. We have so many mental health issues that our mental health system really needs the psych mental health nurse practitioners, but all of us in primary care need to be able to address and at least get them started in some mental health intervention. Because, where I practice, it could be 6 months to a year before we could get someone into mental health services, unless they're really going to cause harm to their self or others. Futurists' prediction says that continued emissions of greenhouse gases will lead to further climate change, and future changes are expected to include a warmer atmosphere, which we know, a warmer, more acidic ocean, higher sea levels, and changes in precipitation patterns, which we're already seeing. So the question is, what have we learned from COVID-19? Are we prepared for the next pandemic? I don't really think so, because I don't think that we really, some people don't even believe COVID-19 happened, unless you're someone like me and had several family members die or almost die. you might not have been impacted by it. And, you know, I don't know about you, but I'm seeing more insect-borne illnesses. Pennsylvania, we have the highest rate of Lyme disease in the country. I thought when I had COVID last year, I had it again this year. I was pretty sick, and my husband was sick in the other room, and I, was making him tests for it. It wasn't for months later that we learned that he had Lyme disease. We never saw a tick. We never saw a bullseye rash. West Nile, supposed to be West Nile, not wet now, but I guess it does live in wet places. We're seeing more of that in some areas, and bee stings. I don't know about you, but we're seeing bee stings that are causing cellulitis and causing a lot more problems. The bees seem to be the ones that are existing. Is probably maybe more wasp, and other stings are a lot worse. And I'm also seeing a lot more allergies related to fields of goldenrod and ragweed, and really bad cases of poison ivy, poison oak, and poison sumac. We know that our water is being contaminated. We saw all of the issues on the news about underserved areas. We're seeing contaminated and dead fish, and we're also seeing more contaminated wild meat. We have a lot of hunters in Southwest Pennsylvania and in West Virginia, probably in Kentucky. But, when the animals have Lyme disease and other diseases, we're not sure, if they're safe to eat. So I was going to tell you a story about contaminated water. When I used to practice with Mona Counts down on in the border of West Virginia and Pennsylvania, there was a small creek, whatever, however you want to call it, that ran through the town. And one day I was in the only provider at the clinic, and a man comes up and he knocks on the door and he says, "Where's Mona?" And I said, "Well, she's not here today." I said, "Can I help you with something?" "Yeah." I said, "Okay, well, what's the problem?" "All the fish are dead." I said, "The fish where?" He said, "Down in the creek." Well, when I look at that creek, I didn't think there was any fish in it. Really. I never thought there were. I was shocked. I said, "Well, I have one more patient to see, and then I'll come down and look at it with you." And I'm thinking to myself, what does he want, or what does he think Mona would do? Like give CPR to these fish? I mean, I don't know. And so I was really shocked and devastated when I went down, because there were dead fish all over the sides of the banks of this little creek, whatever you want to call it. And there were some that were still dying, like flipping around. And so I said, "Well, I'll go back and I'll call the DEP." And he's got a mouthful of snuff, and he spits and he says, "Oh, they ain't going to do nothing about it." And I said, "Well, I don't know. I'll call the state and the federal, and we'll see, what can happen." Well, it happened that one of the coal mines in the area released poison chemicals into that a creek, a tributary to that creek that ran into a larger stream, and it killed all the fish. And I'm wondering how many contaminants are in there to come. They were fine, but really just a slap on the wrist compared to the damage that was done in that area. So what we're all tired of talking about, COVID-19. I think we have some benefits that we have to think about it in terms of more self-care. If we look at outcome 10 of the Futures Report, that most of us are trying to do more self-care. We're trying to lose weight because we know more obese people and more people with uncontrolled diabetes were dying from it. Some of us during COVID-19 were visiting friends and relatives, or calling them or Zooming them more often, because we started to see how important the connections were. I think it's great that they started grocery delivery, and it's still going on, because for nurses and nurse practitioners and us people who are working all the time, that is just such a great avenue and opportunities to work at home. Although I do think we're seeing some of that change. My daughter worked for a big an auditor for a big insurance company, was working at home. Her job description said she was a remote worker. She didn't have an office there or anything. And then just a few months ago, they said you have to come back to work 3 days a week. The reason she left a much higher paying job at a financial bank as an auditor to take that job so she could work at home and not have to drive to the city. And now she was going to have to drive to the city and make less money. Um, and they're just sitting in a big seat in a big open area where they don't even have privacy in their work. So they really weren't really prepared for people to come back to work. But some people were able to keep their opportunities to work at home. I think the real benefit is yet to be seen, and that's the creativity that will be applied and will be blossomed over time. And I think nurse practitioners and nurse midwives and nurses are creative, and we can find ways that we are going to see change over time. You know, chaos theory tells us that the most creative places are changes, and the most creative places in the universe is at the edge of chaos. And I think our country is certainly in chaos today. And I think our healthcare system is in, if you look at the percentage of the gross national product that's being used for healthcare, we really need to use our chaos to find ways to make change, because we are certainly at the edge today. Can we apply creativity to an increasingly diverse world that we live in and be our most innovative selves? I'm asking you that because we need you to be the leaders that can do that. This is a sad note, but I think we're seeing it. The world will be more fragmented and compartmentalized. Expect countries to look out for themselves at the expense of rules-based systems and at the expense of poor countries. And I think we're seeing some of the work that's being done in Africa and others by large countries that are exploiting their minerals. To extent that there is cooperation, it will be among democratic rule of law states on one side and authoritarian states on the other. This is from William Readiness. The era of whack-a-mole, chain supply disruptions. Every month it will be something different, and it won't be the same everywhere. So think about toilet paper in 2020, maybe food in some areas because of the wars, critical minerals, semiconductor chips, you know, we're talking about now, who has the greatest amount and the trend for those. Supply and demand seems to be out of whack, and the system is having trouble turning to a stable equilibrium. Global integration guarantees these spill over and are not geographically isolated. So again, what happens in one place happens everywhere. So I'm going to leave you with some questions, and maybe we have some time to talk about it, but how will nurses help with public health issues that arise in the future? Because they will help, they will happen. Many states, particularly in the DC area, are really vamping up and learning from COVID-19 so they could be prepared for that next pandemic, whatever it will be. And how could we ensure that there's equity in whatever we do in this healthcare system? Because we're still not seeing it, despite having more access to insurance programs. We're seeing states that are getting rid of their Medicaid expansions, seeing more people becoming uninsured again. And then how will we address the ongoing issues with women's health? And I'm not just talking about the abortion debate. I'm talking about overall general women's health and some of the things that are happening in some of the states where the midwives and the OBGYN and the women's health NP providers are leaving because they're not feel like they're safe. And this is really impacting the low income areas that we serve and impacting those areas with minority populations and probably the people who really need prenatal care and other care the most are not getting it. We're talking about some rural areas where they have to drive hours to get to care. So I'm calling on the CNMs in the group to think about how you can imagine going back to a model where the midwife comes to the home and takes care of the mother and the family. How are we going to do that? And the other question is, how can we sustain ourselves and make money doing it? Because, that's the kind of world we live in. So as long as nurse practitioners and even midwives to some extent, although they're more independent in many ways, as long as we're tethered to physicians, and I would say to healthcare systems, our ability to improve access to care becomes limited. So I'm asking you as nurse leaders after this talk today to be the sentinel, to watch out for that unexpected legislation in your state that might impact your practice. I know you don't think they listen, but you have to keep harping on them, and you have to keep at it and get your colleagues and get your patients and get everyone to be on them, and eventually they'll listen. And it takes a lot of work, and sometimes you don't get a lot of gain at first, but maybe hopefully over time. It's said that good leaders make people feel that they are at the very heart of things, not at the periphery. As you are a leader in your school, in your practice, in your community, make people feel like they are a part of it. I think that's why there's so much turmoil in this country, that so many people feel that they're a part of the periphery and they're not part of the heart of what's going on in the country. How can we make them feel like they're part of their healthcare and that they're involved in making those decisions? How can you use your voice, nursing's voice, to make people feel that they're the patient, that they are the center of patient-centered care? And that nurse practitioners in your other clinic, office, or unit are at the heart of activities helping patients with their patient-centered care, but also making sure that the health system is keeping the patient in the patient-centered care. If they're talking about physician team-led care, they're not talking about patient-centered care. They're not necessarily talking about what's best for the patient. Be an innovator in your practice. It could be a small practice change that you're making. Our DMP graduates are innovators in making those systems changes in their practices, and they could share those with others so that they can take that and move that forward. Be that voice for your patient that you care for every day, and make sure, above all things, that you take care of yourself. Remember, the future is only as bright as you make it. Let's create a more equitable world, a healthier world, and let's embrace and lead changes in healthcare. Let's be the force that uses technology to benefit patients in society, because I know together we can do it. So I thought I might have some time for discussion, but probably not, since I'm already ran over. But I want you to really think about, what is happening in your practice and how can you make a change, even if it's just a small change. And think about the healthcare issues in the United States, and how can nurses, nurse practitioners, nurse midwives be the leader of that change. And then after this talk is over, just take a minute to think about how you have, because you probably already have been change agents, or how will you continue to be or be that agent of change? And how will you build a better tomorrow? And there's my references.
How about we open up for questions for a few minutes?
You did a great job, Joyce.
Thank you.
It was a good, here, I'll turn my video on for a minute. It was a good rally cry for everybody to hear that message.
Thank you.
Well, I'm going to just take this time real quick to thank you so much for such a really informative and engaging presentation. It's really been a pleasure having you, and we hope to have the opportunity to have you, to learn from you again in the future. I think this was wonderful.
I'm delighted. I really enjoyed it. And back when I was at Frontier, we just started the honor society that you had to start before you started the Sigma group, and I was in the Frontier Honor Society. I'm sure Nancy was too. So so it's really nice to see that it's growing, and all the good work that all of you are doing in terms of really working for the goals that I'm talking about, improving equity and diversity, inclusion, and really, in my opinion, justice, healthcare justice for all.
Thank you. We're working pretty hard on that right now. So yeah. So, and the just for those listening to this, the link for the CE credit is in the chat box as well. So it's there for
you. Thank you so much. Yeah, we have to address burnout, somebody said. And I think that we could be coaches for each other in how to address burnout and how to take care of ourselves more effectively. And for our psych NPs, how not to be afraid to take medications, if you need to, or medications to lose weight. I mean, we're so averse to all of those things still in our healthcare system, and how can we advocate to make change?
So I just want to bring up Mary Kay Miller wrote early on about the frustration with the legislature, and get any of your thoughts on that.
Yeah, I mean, it's very frustrating, just trying to get full practice authority in Pennsylvania has been, a nightmare. We've been working on it for many, many years. It's back in the legislation again. We've had one person in the House of Representatives hold it up every time his wife's a physician. We just keep at it. We'll wear them down eventually, I think. And then in West Virginia, the governor, I think it was Joe Manchin actually at the time, did not want to add any more providers to impact the already bad opioid crisis. But the problem was, we tried to say it's not really us because we're not prescribing those medications. So you're addressing you're looking at the wrong area and the wrong people. But in order to get at least part of our practice without collaboration, we had to accept that you couldn't do Schedule IIs without a collaborative agreement, which probably let more nurse practitioners in trouble, because they went to work in pain clinics where they were the ones that were, because they weren't doing the procedures, they're writing the prescriptions, and so then they get hung for doing it. So it really didn't help it, I don't think any. But and then I think you see like in New York, just small changes over time, where they got down to a piece of paper in a drawer, and finally this year they got rid of that piece of paper, and they really did a really good job of keeping their statistics, having those barriers removed during COVID. Of course, they were in quite a crisis with COVID in that state. They kept the statistics about what the nurse practitioners were doing, how they expanded care, how they made better outcomes. Take that back and got that piece of paper gone. So I think at first they don't listen, but you just have to keep on it. And sometimes it's tiring, and I'm getting worn out at my age, but but I think we have to keep at it. This past weekend, Dr. Ford was able to go have breakfast with President Biden. She's a World War II veteran. So I'm sure that if she had a chance to get a piece of her mind in his ear, she would talk about nurse practitioners. And so anything that we could do is part of what we could do, because, our patients are dependent. I look at my patients, and I think they couldn't stand up and speak for themselves. And so I have to be their voice. Yes, Mary Kay Miller, you're in Florida. I know. It's just, Florida is Florida. You should talk to Anita Lennis, or is she still in Florida? She's the midwife that I was talking about earlier, that had the practice there, and what she did to get around some of the things there.
Well, we can get around it as long as we want to pay for the physicians to sign a paper. But, you can't even open up a plain office if you're a midwife without a written transfer agreement with a hospital, as well as a written referral agreement with a physician for what they call autonomous practice. Otherwise, you can practice on the supervisory side and just have a written protocol and agreement with a physician.
Yeah, I think
All,
there's,
all
and I think
restricted.
it's easier for people probably to go that way because they just don't want the hassle.
Well, there's no hospitals that are writing written agreements because of
Right.
risk management. That's right.
Yes. So it just that those are those local systems level changes that are actually sometimes harder to make because, you know, most of their boards are run by physicians
Yeah,
or
and I'm not getting, we
members
don't,
of healthcare systems, you know, insurance companies.
sure, sure. We don't give up. It's just that I can't believe these amazing, smart surgeons do not want, they do not want to listen to the outcomes, the evidence, and actually what people do want. And we have to wait and try and try. And I mean, literally, moms and babies are suffering. I just can't
There's a
believe it.
really good book. I think it's out of print. I'm looking for it now. I hope I didn't lend it to somebody. I'll get it back. But it's about the monopoly of medicine over nursing. And it really talks about some of the issues. In fact, some of the very same jargon that they use against us today, they were using in the 1800s against nursing practice. So it's not changed. It's not changed.
Yes, that's the disheartening part. That's the
Yes,
part
it
that
is.
is unbelievably
But it
painful.
also can keep you going. Like when I get real depressed about what's going on in the world, I watch some Johnny Carson reruns. And I never really liked Johnny Carson, but the other night my husband had it on and they were talking about the war in Israel. And then I heard something that was said and I didn't recognize it was Johnny Carson's voice. And I ran in and almost sounded identical to what's going on now, but it was like in the 1980s. So it makes me think that nothing changes and that we're going to be all right. But that's at least what I'm hoping for.
We have one more in the chat from Laura. It says, for those of us who are not caring for only underserved, how can we support our colleagues who care 100% for this population?
I think that supporting any efforts for full practice authority in your state, and you're in Tennessee, right? So it's a restricted state still. I think that's important to work on those issues because, look, if I'm tethered to a physician, I'm going to have to practice close to or where they are. And if they are only in cities, am I going to be out in you know, Clay County, Kentucky, or you know, in the middle of nowhere, Tennessee? No, because I can't do it. So if we really want people to go in and work in these places, everyone needs to advocate, and nursing instructors and professors need to teach the students, the midwifery and the NP students, about the issues and teach them how to advocate for themselves when they get out of school. And I think we're also oh, North Carolina, you're in North Carolina. I'm sorry, Laura. I knew you were in one of those states. But you know, if we think about some of the things that are, you know, maybe being written out of some of our legislation, you know, our guidelines, you know, policy is not necessarily there like it was. And we have to watch that because we'll get nowhere if our students don't know how to do policy. I hope I answered your question, Laura.
I think you answered all the questions. Thank you so much. This was wonderful.
Well, have a great evening and have a very grateful Thanksgiving.
Thank you. The same to you.